Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week sessions again. So tonight we're going to do cardiology session 2. I hope that you guys enjoyed our last session on cardio, where we discussed extensively on chest pain. So do you guys have any questions on our last class where we discussed about chest pain cluster mainly? All right, I guess no. So again, we will do a role play session on those topics anyway. So if there is any questions, we will be able to find it out at that time as well. So as you know that this is our free 2-week sessions, and it means that it is also part of the course classes as well. So for most of you, I know you are already enrolled into the course, but for some of you, you might just doing these 2-week sessions to understand how we take our classes and get to know about us. So I'm sure that you are learning about the classes, the type of classes. You already had another session with Dr. Cynthia, which was basically on role play session. So our course classes are divided in this. So we take theory sessions like how we are doing here now, and also you'll do those random role play session. Those are random cages, but also as part of theory class, we do theory role play session as well. Like when we finish cardio, we will do a cardiology role play as well. So it's a mix up of everything. And if you can cover all the topics, everything that we are discussing in the class, that will be more than enough to pass your clinical exam in the first attempt. That I can assure you. But again, you need to do your hard work. You need to do a lot of role plays, improve your communication approach. And if you can do that, there is no way anyone can fail you. Okay? So let's start with another cluster of cardiology today, which is super important cluster, syncope cluster. So syncope cluster covers a lot of important topics that comes in exam almost every month. So syncope means sudden loss of consciousness, and sudden loss of consciousness can be due to multiple reasons. So you need to know the differential diagnosis of syncope first. So most important is cardiovascular system. Then we have central nervous system, and then there are lots of miscellaneous causes. For cardiovascular, it can be arrhythmia, like any kind of arrhythmia can cause syncope. Even atrial fibrillation, SVT, VFVT, all of those arrhythmia can present as syncope as well. Aortic stenosis is a very important topic, so that can come as syncope. HOCM, which is hypertrophic obstructive cardiomyopathy, can present as a syncope, especially in young patient. Myocardial infarction, ischemic heart disease, that can be a possible differential. And sometimes prolonged QT syndrome can also present as a syncope. You could keep the prolonged QT syndrome under arrhythmia, but I kept it separate because this is an exam case. So we need to remember those cases which comes frequently in exam, just so that we don't miss this in our exam. So for arrhythmia, only thing that comes in exam under arrhythmia is this prolonged QT as part of syncope cluster. But I have seen that even sinus bradycardia comes under arrhythmia. Sometimes sinus tachycardia even comes as under arrhythmia. I have seen a case where patient had frequent fall or dizziness, and the only finding was sinus bradycardia. So any arrhythmia can present in the exam as syncope. So we need to be very conscious about it. We need to keep our eyes open. In exam, the first thing we say that do not enclose yourself in a shell, that you have done some cages, you know some of the questions which is important, and that's it. You will not go beyond that. It is not how it works in exam. In exam, any case, anything can come. So the classes that we take is for you to understand how to get into the right diagnosis. The classes are going to help you to know the cases, but exam sometimes will test you. Sometimes if you are just thinking in a closed shell where you can't get out of that shell, that is one of the reasons some of the candidates fail in the exam. So just remember one thing, that any of these differential diagnoses can come in the exam under syncope. So don't just think that, well, I know that prolonged QT comes in exam, so that's all I would think. No, any arrhythmia can come in exam. Okay, so aortic stenosis is important, prolonged QT is important. I haven't seen any case coming as a syncope in a MI patient. The MI patient usually comes as chest pain, but still we need to rule that out. Then central nervous system, so TIA or stroke, head injury, infection, basically meningitis, encephalitis, and epilepsy. Epilepsy is very important cause of syncope. Others. So lots of others, right? So vasovagal syncope is important. Postural hypotension can come as syncope. Even sometimes hypoglycemia can come in the exam as syncope. Anemia is another important. Sometimes medication, especially polypharmacy, especially antihypertensive, like elderly patient on multiple antihypertensive like diuretics, ACE inhibitors, even furosemide. So they can end up having a fall because of hypovolemia or hypotension. So medication induced can be the cause in exam. Even there was a case long ago, which was a young girl came to you with a syncopal attack, and it happened in the morning. She suddenly tried to open a drawer in her kitchen, and suddenly she fell and lost consciousness. There was nothing else. And if you don't know that alcohol hangover can cause syncope, you will never be able to come to the diagnosis in the exam. So alcohol hangover, especially if you ask the questions, you will find out that that girl went to a birthday party for her friend, and then ended up having a lot of binge drink, and in the morning she ended up getting a hangover. And even binge drinking can cause hypoglycemia. So hypoglycemia, dehydration, a lot of things can cause this syncope in this patient. So that was also one of the things that we should know of. This is important to know that if a reproductive age group female presents as a syncope, we will definitely rule these common ones first, but do not forget about asking the reproductive causes. Like even a pregnant patient sometimes can feel dizzy. They can have even loss of consciousness. So rule out pregnancy, rule out ectopic pregnancy, which is important. Rule out whether they are having like excessive bleeding during period, which is menorrhagia. And because of that, they are getting iron deficiency anemia causing this syncope, right? Now, these are common causes. If you have been practicing in Australia or anywhere in the world, you will know that this is a very common presentation, right? So common things we tend to forget in the exam, but those can come in the exam in no time. So very important to remember these common things. And do not forget about psychological. So stress, anxiety, psychogenic causes also can come as syncope. Okay, so these will be our main differential diagnosis for syncope or sudden loss of consciousness. Among these Differential diagnosis, the exam cases we have seen so far, there is aortic stenosis, which is also a handbook case. We have got prolonged QT. I've seen epilepsy, not that common. Vasovagal, postural, these are super important. Hypoglycemia, anemia, alcohol hangover. So all of these are exam cases. So as you can understand that this is why it is a super important cluster for exam. And just by using a same history format, same physical examination format, you can cover 8 to 9 cases. And that's how the smart people will prepare for this exam, because no one can remember 9 cases differently. If we can bring 9 cases under a cluster and then just know the management, that becomes nice and easy. That becomes a very smart way of preparing for your AMC clinical exam. Okay, it's not only just for exam, it's also for your whole life. You will be using the same thing in your whole life when you are seeing such a patient in your real life. Okay, so this is going to prepare you for everything. So how to take a history for a patient who presents with syncopal attack. So patient, let's say 50-year-old patient coming to us with sudden loss of consciousness yesterday. So you need to take a history from the patient, physical examination from examiner, and give your diagnosis, differential, and possibly management. So how we are going to start? So our history is more or less, now you know how to start the history. So you can always say that, hi John, this is Dr. Arshan, very nice to meet you. I understand that you had a loss of consciousness yesterday. I'm so sorry to know that. How are you feeling now? John says that, yes, Doc, I'm feeling all right now, but I'm very concerned that I have never had this fall before. So I want to know what's causing this. So you'll say, well, yes, I understand that loss of consciousness can be quite frightening, but I want you to know that you are here with me, and I'll try my best to find out the cause and manage your condition. But before I ask you any more questions, John, I need to talk to my examiner to make sure you are stable. So please excuse me for a moment. You turn around to the examiner, and examiner, you ask that, dear examiner, is my patient vitally stable for further history? Examiner can say, what do you want to know? So you'll say, I would like to know the blood pressure, including any postural drop, pulse, rate, and rhythm, please. I would like to know the respiratory rate, temperature, and oxygen saturation as well. So it is very important in this case because arrhythmia is one of your differential diagnoses. So if there is any atrial fibrillation, then you will find it out. Pulse rate will be elevated if it is arrhythmia. So that's why rate and rhythm. Blood pressure with postural drop, because postural hypotension is a super important case for exam. That's why we are asking that blood pressure with postural drop. Okay. Once we have done that, then we come back to the patient. So thank you, John, for waiting. So John, now would you please tell me a little bit more about what exactly happened? So when we are talking about the syncopal cluster, we divide the presenting complaint, and our presenting complaint is syncope. We divide it into pre-syncope, so what happened before you lost consciousness, syncope, so what happened during your loss of consciousness, and what happened after you regained consciousness, which is post-syncope. So first, always start with open-ended question. So can you please tell me a little bit more about what exactly happened yesterday? So this patient will give you some idea that I was just like walking on the street, or I was just playing tennis with my buddy, and then suddenly I collapsed. Or then I felt a bit lightheaded. I was having a bit of chest tightness, and I was a bit short of breath as well. And then suddenly I felt that I'm going to fall. And then in no time, I just fell on the ground, and I can't remember what happened after that. So something you will find out from the patient. whatever you don't find out, whatever is not in the stem, then you will ask in detail. So what exactly were you doing at that time? Now, this question is not needed if patient already mentioned that I was playing with my friend, I was running on the street. So if patient already say what he or she was doing, then we don't ask it. So we move on to the next question. So did it happen for the first time? Did you fall suddenly, or did you feel any lightheadedness or dizziness before you fall? Why it is important? Now, if a patient had a fall suddenly and they regained consciousness suddenly, that's cardiogenic syncope. That means something cardiologic is there. So they will fall suddenly, they will lose consciousness suddenly without any prodromal symptom, and then they will also regain consciousness very quickly. Whereas if it was a vasovagal syncope or autonomic syncope, they will have some prodromal symptom. They will get a bit of lightheadedness, dizziness. They might even feel a bit nauseous. They might feel hungry, sweaty, and then they can fall. So when there is a prodromal symptom before losing consciousness, it's likely to be autonomic. And most commonly, it could be related to vasovagal syncope. So did you fall suddenly, or did you feel any lightheadedness or dizziness before that? Any headache, any blurring of vision, any weakness in any part of the body? Okay, so ask about any headache, blurring of vision, any weakness in any part of the body. Why is it important? It's important to know because sometimes if it is related to any kind of CNS problem, like we are asking about stroke or TIA. Yes, Anna, very good. So stroke and TIA will have this kind of symptoms: headache, blurring of vision. They can have weakness in some part of their body. So that's why we're asking it. Okay. Then that's enough for pre-syncope questions. The next question is syncope. So what happened after you lost consciousness? So the first thing is that, did you lose consciousness? Because many times patient might just have a fall. Patient might feel to be dizzy. That's not syncope. So we need to ask directly, if it was not said by the patient yet, that did you actually lose your consciousness? Yes. Was there any weakness? Now, definitely there will be a witness, right? Because if patient was playing with his body, then the friend might be the witness. So was there any witness? Did you actually lose your consciousness? Yes, doctor, my friend was there. All right, so did your friend say how long you lost your consciousness? Did he see or did he notice any jerking movement of your body? Did you wet yourself or pass a stool? Did you bite your tongue? Did you injure your head by any chance? Okay, so was there any witness? Any loss of consciousness? How long? Any jerking movement? Did you wet yourself past a stool? Did you bite your tongue? Did you injure your head? So these will be the questions for syncope, like what happened during syncopal attack. Just 1 second, guys. I'll just open one other thing for you. Just give me 1 second. Excuse me for that. Okay, So we were talking about syncope. So we know about pre-syncopal questions. Now the syncope questions mainly to make sure that patient lost consciousness. That's important to confirm. We need to know how long. We need to also make sure that there was no sign of epilepsy. So we ruled out all the epilepsy questions by asking this. And head injury is also important because if they hit their head, that's another problem. Next, post-syncope. So we want to know, after you gained consciousness, were you able to stand by yourself or someone helped you? Why it is important? Cardiogenic syncope, the patient will say that I lost my consciousness, and then when I regained my consciousness, I was able to just walk by myself. I did not feel any problem. Because cardiogenic syncope is like that. They lose consciousness very quick and they regain consciousness also very quick. So after you gained your consciousness, were you able to stand by yourself or someone helped you? If patients say, no, I couldn't, I was feeling very confused and drowsy. I couldn't stand. My friend needed to support me to take home. That means after syncope or after regained consciousness, patient was still having a bit of confusion or drowsiness. And that goes more with neurological problem, that goes with epilepsy, because epilepsy patient has post-ictal confusion. So they get this seizure or convulsion, and after regaining consciousness, they can have this confusion lasting for even 30 minutes to 1 hour, sometimes even hours. So did you feel confused and drowsy afterwards? Any weakness, any problem with your vision or speech? Same, we're still trying to rule out any stroke or TIA. Okay, so now we asked all the presenting complaint questions. So we asked pre-syncope, we asked syncope questions, and also the post-syncope question. After that, we move to the differential diagnosis. There are lots of differential. So first, start with the cardiovascular. Any chest pain, any shortness of breath, any racing of your heart. That covers most of the things. So racing of the heart will cover arrhythmia. Shortness of breath, chest pain covers everything else. Like if it is myocardial infarction, then chest pain, shortness of breath will be there. If a patient has aortic stenosis, they also get chest pain and shortness of breath. So that these three questions cover the whole CVS differential. Then for central nervous system like stroke TIA, any head injury. Now, if you forgot to ask the head injury here, then at least ask it here. Head injury is really important. Any fever, rash, any neck stiffness. Or even you can say any fever, rash, neck stiffness, any headache to rule out meningitis, encephalitis. So if we go to the CNS causes, we already asked all the TIA stroke question by asking about any problem with your vision, speech, headache, weakness. That covers TIA stroke. We asked head injury. We now just asked the infection question. And we also ruled out epilepsy during our syncope questions. So these two main system is done. Now we go to the miscellaneous causes. So first we have got hypoglycemia. So by any chance, you skip your meal yesterday. Now, if it happens today, then today. If the syncope happened yesterday, just say that, did you skip your meal yesterday? Because skipping the meal can be a major factor of syncopal attack. Especially, let's say patient did not eat anything and then ended up for jogging for like 10 kilometers. And they can definitely feel a bit of hypoglycemia and they can even lose consciousness just for that. So you can always ask that, by any chance that you skipped your meal yesterday? And you can also add that any history of high blood sugar or diabetes. Then we have vasovagal. For vasovagal, there is no specific question that we can ask. But if you want, you can always say that, was it a hot, sunny weather? So patient usually gets the vasovagal syncope. Either they were sitting or standing for a prolonged period of time, or they might be just doing overexertion in a hot, sunny weather. So that's usually the common presentation. So you can say that, were you sitting or standing for a long time? Was it a hot, sunny day? Were you doing anything exertional? Okay, so for vasovagal, these questions we can always ask. So standing or sitting for a long time? Was it a hot, sunny day? And then were you doing anything exertional yesterday? Okay. Then we have postural hypotension. For postural hypotension, we ask the patient, do you feel dizzy or lightheaded when you get up from the bed in the morning? This is a very good question to cover postural hypotension. So do you feel dizzy when you get up from the bed in the morning? Or do you feel dizzy when you change your position? So feeling dizzy or lightheaded during changing position, or when they get up in the morning, that's the more or less the same questions. And postural hypotension patient usually will have this kind of complaints. So they will always say that I feel dizzy or lightheaded, especially when I get up in the morning, or when I change my position from when I stand from sitting position, I feel dizzy. So that will be our questions for postural hypotension. For anemia, do you feel tired these days? Anyone mentioned that you look pale? Remember, if we get anything positive, then we go a little bit more detail. But if we don't get positive, these are only questions that we ask. Like if postural hypotension was positive in here, then there are lots of other questions that we need to add. That we are going to show you when we do these respective cases. But for a simple cluster format, these are only questions that we need to ask. Okay? So for severe CNS, we asked hypoglycemia, did you skip your meal, any history of high blood sugar? Now, yes, if the patient has a history of high blood sugar, Anna, then you can go in detail, like how long you have been diabetic, is your diabetes well controlled, what do you take for diabetes, do you take any medication or insulin? So there are a lot of questions it comes when we get something positive. Okay, but in most of the cases, this might not be positive at all. There is a case which comes as diabetic complication. We will discuss that more. In that case, like if we want to find out that if the insulin is causing the hypoglycemia and that caused the syncope, then we need to go into detail. The patient will say, yes, I take insulin. We need to then ask that how long you have been taking it. When was the last time you checked your blood sugar? What's your HbA1c looks like to find out is it well controlled. And then we find out that did you take your meal after having the insulin yesterday? Because patient might say that, well, I forgot to take my meal after having the insulin. Or did you do anything unusually exertional yesterday after having the insulin? Because a normal person, if they take an insulin, but they do something really unusual, like they never go out and run, but suddenly yesterday he went for like a marathon running, or he went for a hiking. That is unusual exertion, and that can always cause hypoglycemia because insulin might drop the sugar quite fast. So a lot of questions come if we get something positive. If we don't get something positive, then we just stop here. So now we asked about severe CNS, hypoglycemia, vasovagal. We asked about postural hypotension, anemia. If it is a female patient, then we will also ask about their period. So you will say that I'm going to ask about your period and also your sexual life. Is that all right with you? So take a permission, it's a good idea. So when was your last menstrual period? Is it regular? Are you sexually active? Is there any chance that you can be pregnant? Do you take any contraceptive? That will cover most of the things. So we want to know what's your last menstrual period. Is it regular? Do you get excessive bleeding during your period? Are you sexually active? Do you take any contraceptions? Is there any chance that you can be pregnant? So these will be our questions for if it is a female patient in reproductive age. And lastly, we will just quickly ask about their stress. So is there any stress at your home or work? Do you have any other past medical condition, any history of diabetes, high blood pressure, or any heart disease? Do you smoke or drink alcohol, any recreational drugs? Do you take any regular medication? Medication history is super important because there are lots of cases which comes as a side effect of medication under this cluster. And any family history of sudden death, especially related to cardiovascular or especially related to heart condition, any family history of any specific heart disease. Okay, so family history of sudden cardiac death, it indicates HOCM or prolonged QT syndrome. This is usually the commonest clue. So if they say yes, there is a sudden cardiac death in a young age, then we should think of HOCM or prolonged QT. So how to ask about vasovagal cause? Vasovagal, you will know that it is vasovagal based on the syncope presentation. So when you ask all these pre-syncope, syncope, post-syncope question, you will already know that it was most likely a vasovagal because they will say that I was running marathon and then suddenly I was feeling lightheaded and dizzy. I also felt quite sweaty and hungry and then suddenly I fell. See these prodromal symptoms, that gives us the finding that yes, it is likely to be vasovagal. If we don't get that, if we just want to ask question, then we just ask that were you standing or sitting for a long time? Was it a hot, sunny day when you had this episode? Did you do anything exertional on that day? So that will cover if there is anything that can cause vasovagal in this patient. Okay. So to recapitulate this history format, so you'll start with grit, reassurance, make sure patient is vitally stable, go through all these questions, then the differential diagnosis including CVS, CNS, and then you just ask all the others, hypoglycemia, vasovagal, postural hypotension, anemia. If it is a female, ask about these reproductive causes, stress, and then finish with past medical history, SADMA, and family history. Clear everyone about the history format? Okay, now the history is done. Thank the patient and say that thank you, John, for all the information. Now I'm going to talk to my examiner and come back to you. So then you turn towards the examiner and your next task is physical examination from examiner. So you'll say, dear examiner, I would like to do physical examination on my patient John. First, on general appearance, is my patient comfortable or in distress? I would like to know the vitals. So if you haven't got the vitals yet, then you ask the vitals again in here in detail, which means blood pressure with postural drop, heart rate with rhythm, and the others. BMI, ask BMI in any cardiovascular, we would ask about the BMI from examiner. Then we have pickled. In the pickled, the main in here would be any pallor, and you can ask about any edema, dehydration as well, because dehydration can be a cause of syncope. If patient presents immediately after the syncope, then this is more relevant. Otherwise, if it happened yesterday, then it's not that relevant, right? So ask about any pallor, any not lymphadenopathy, any pallor, any edema, or any sign of dehydration. And then you'll ask about the neck. So first I'll start with the neck, any raised JVP or carotid bruit. Then we go for CVS. Now remember we discussed this thing in our chest pain cluster. It is exactly the same. So that's why that the format really helps. With one format, cardiovascular physical examination is done. That means the physical examination from examiner. So nothing else we need to add. Just make sure that you ask about the CVS in detail. Ask about the CNS, so that you will say that I would also like to finish with full central nervous system examination, including cranial nerves. And I would finish with all other systemic exam, any office test available, such as urine dipstick, blood sugar, and ECG. So we discussed this in detail in our last class on chest pain. So I'm not going into that again. Okay. Do you guys have any questions that how to do this physical examination from examiner? CNS, central nervous system, because central nervous system is one of your differential, right? So you will just say in here that I would like to, so let's say we start like this. Let me just show you how we would do it. So dear examiner, I would like to do physical examination on my patient. First, I would do general appearance. Is he comfortable or in distress? I would like to know the vitals and BMI, please. On vitals, I would like to know the blood pressure with postural drop, rate, pulse rate with rhythm. And I would also like to know the respiratory rate, pulse rate, and respiratory rate, oxygen, and temperature. Any pallor or any sign of dehydration, any edema. Then I would like to check the neck, any raised JVP or any carotid bruit. I would like to do full cardiovascular exam. On inspection, any visible cardiac impulse. On palpation, is the apex beat normal in position? Any palpable thrill or parasternal hip? On auscultation, apart from S1, S2, is there any added sound like any murmur? Then I would like to do a full central nervous system examination, including cranial nerve exam. And then I would finish with all other systemic exam. Is there any office test available, examiner, like urine dipstick, blood sugar, or ECG? That's it. You don't need to say in detail, because in physical examination, only one system, the most relevant system, you will have to ask in detail. Others, you can just ask like this. Brilliant. Now let's move on to the cases one by one. So first case that we are going to do is aortic stenosis. This is also a handbook case. So you are a GP. Your next patient is a 52-year-old male who is consulting about recent loss of consciousness. You have to take a focused history, physical exam from examiner, ask for investigation and diagnosis with management. You will not get this much task in exam. Face-to-face exam, mostly the task is highest you get 2 to 3 tasks. You rarely will get 4 tasks in face-to-face. Now, we no longer need to ask, or we no longer need to talk about the history, because we know what kind of history we are going to ask, right? So when you ask that history in this same case, you will find out that patient will say that I was playing tennis and started to black out. I've been also having shortness of breath on exertion for the last 2 months. And also I feel chest tightness. So this is the triad of aortic stenosis: chest tightness or chest spasm with shortness of breath on exertion plus a blackout or dizziness or syncope. So if these three things are together, you can think that it's likely to be aortic stenosis. It is common in elderly patient or old patient. If you do physical examination on this patient, you might find that the left apical impulse might be displaced a little bit towards the left side. But most important finding, which will give you the diagnosis, is the murmur. So it's a good idea to know about the common murmur in the exam. Like aortic stenosis murmur is really important. So it's an ejection systolic murmur in the aortic area radiating to the neck or carotid. So if you want to know that what is the commonest ones, so because murmur comes in exam, especially I have seen mitral stenosis, mitral regurgitation, aortic stenosis. All these three I have seen. So aortic stenosis murmur is ejection systolic murmur. The best way to remember this is remember only one murmur, which is mitral stenosis murmur. Mitral stenosis murmur is mid-diastolic murmur. I always remember like this, that I keep mitral and aortic as opposite and stenosis and regurgitation as opposite. So what is the opposite of mitral? Aortic. Just for the sake of remembering, it's actually not opposite. What is the opposite of stenosis? Regurgitation. So these two are diastolic murmur. And aortic regurgitation is an early diastolic murmur. Okay. Now, whatever left is systolic murmur. So MS, the left is MR, aortic regurgitation, left is aortic stenosis. So these two are systolic murmur. Aortic stenosis is ejection systolic murmur, and mitral regurgitation is a pansystolic or holosystolic murmur. And these two murmur also radiates. Aortic stenosis radiates to the neck or carotid, and pansystolic radiates to the axilla. Okay, so it is important because these two cases, MS and MR, comes in obstetrics. So it's important to remember, and aortic stenosis usually comes under cardiology. Yes, so you have to ask the examiner. So just like how we have asked in here, so one by one you will be asking examiner that I would like to know. So on auscultation, apart from S1, S2, is there any added sound like murmur? When you say that, examiner will say that yes, there is a murmur. Now, will you stop there? No. You need to find out what type of murmur. So you will say, then I would like to know what type of murmur it is. Is it ejection? Is it systolic or diastolic murmur? Now, the best way is just say that I would like to know what type of murmur it is. Examiner, if he is good, he will say the full. He will say ejection systolic murmur. If he wants to just kill your time, then he will say systolic murmur. You know now that systolic murmur can be ejection systolic or holosystolic or pansystolic. Then you have to ask that is it ejection systolic or pansystolic murmur? Then examiner says that it's ejection systolic murmur. Okay, so normally when you say that apart from S1, S2, is there any murmur? Examiner usually say that yes, there is a ejection systolic murmur in the aortic area. They usually give you the full thing, but sometimes they might not. So in that case, you need to dig in. You need to also ask that does the murmur radiate anywhere? Because if it is an ejection systolic murmur, you know that murmur is supposed to radiate. So ask about it. So many murmur things we can ask. So I would like to know the type, characteristic, and intensity of the murmur. If you ask like that, then they usually they need to say the full thing. So I would like to know the type, character, and intensity of the murmur. They will say, yes, you have got a ejection systolic murmur in the aortic area. Does the murmur radiate anywhere, doctor? Yes, it radiates to carotid. See that you're asking questions and examiner is giving it to you. Okay, so that's called physical examination from examiner. Make sense? So now from the history and from the physical examination, you know that this patient has got aortic stenosis. So what will you say? So you'll say that most likely you have got a condition called aortic stenosis. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So you can draw a picture for the patient, like you can say that this is your heart, and your heart has got 4 chambers. Each of this chamber is has a door-like structure known as valve. So your heart has 4 chambers. Each of these chambers has a door-like structure known as valve. In your case, the valve that controls the flow of blood from the heart to the aorta, which is called aortic valve, gets narrowed, making it harder for blood to flow to your for making it harder for blood to flow from your heart to the rest of the body. So if you draw, it becomes very easy for the patient to understand. So this is your heart. Your heart has 4 chambers, and each of the chamber has a door-like structure called valve. In your case, the valve that controls the flow of blood from the heart to this aorta, which is what we call aortic valve, is narrowed. That is why it is hard for the blood to flow from your heart to the rest of your body. That is why the blood supply to the brain is reduced, causing the loss of consciousness. And when you exercise, the demand for oxygen gets increased, but because the heart valve is already narrowed, it cannot supply enough blood and oxygen, causing the chest pain and shortness of breath that you have been having. See that what we are doing in here is that we are correlating patient symptom with the problem. That is the best way of explaining the diagnosis. If you can correlate, if you can say why you are getting this, why you are feeling short of breath, that's the time patient will be more interested to know that, yes, I understand why I'm feeling like this. So you can make it as simple as you want, but the gist of it is your heart has got 4 chambers. Each chamber has a door-like structure called valve. In your case, the valve that controls the flow of blood from your heart to the aorta is narrowed. This aorta takes the blood to the rest of the body. But in your case, because it is narrowed, your heart is not able to send blood everywhere, especially the brain is not getting enough blood supply. That's why you're getting this loss of consciousness. And when you're exercising, the demand of blood and oxygen getting increased, but your valve is already narrowed. So it cannot fulfill that demand, causing the chest pain and shortness of breath that you are having. See that if you can explain like that, like there is no examiner who can fail you in exam. After that, there might be 2 different kind of tasks. One task can be that they can say that give the diagnosis with differential. If they give you only differential, then you talk about differential and say why all the others are unlikely. And in other case, they can ask you to explain the management. So remember in our last class, we mentioned that how to give differential diagnosis in the exam. So if this was just a diagnosis differential task, then you need to say that it could be due to other differential diagnosis as well. Like, then you just think about what you have asked. So it could be heart attack, but you don't have any chest pain. You don't have any current chest pain. And also the ECG did, like if they have given you ECG in the exam, then you can say ECG did not show anything like that. Okay, so it could be heart attack, but you don't have any chest pain or shortness of breath at the moment, and your heart examination found a murmur, which is an abnormal sound, which does not go with heart attack. It could be any kind of heart rhythm disturbance, but we haven't found any racing of heart in your case. It could be some nervous system related problem like a stroke or mini stroke, but you have no weakness, no problem with your vision or speech. Could be head injury, but you didn't hit your head. Could be infection in the brain, but you don't have any fever, rash, neck stiffness. Could be epilepsy, but you did not bite your tongue or you did not have any jerky movement of your body during your loss of consciousness. It could be vasovagal, but given that you lost your consciousness suddenly and you regained your consciousness very quick, it's unlikely to be vasovagal. Could be postural hypotension, where patients usually feel dizzy during change of position. You don't have any symptoms like that. Could be low blood sugar, but you did not skip your meal, nor you have diabetes. Could be anemia, but you are not feeling tired. You don't look pale to me. Okay, so this is how you say differential diagnosis in the exam. And it is always that how many you can say, there is no rule. You say as many as you can. Okay, so that is the deal with the differential diagnosis task. If differential diagnosis is not a task, then you don't need to go that much detail like I have done. You can just say few of the differential and then just go to the management. So this is an emergency department, right? Sorry, it is a general practice. So first, if it is a general practice, what we are going to do? So first I will do an ECG and an echocardiogram to confirm the narrowing and its severity. So GP can organize ECG, GP can do an echocardiogram, and echo will be able to confirm that yes, it is aortic stenosis, and it can also mention its severity. Based on the scan report, I might refer you to a heart specialist for further assessment and treatment. Treatment depends on the severity of the narrowing and the patient's symptom. If the narrowing is not too bad and you don't have severe symptoms, then a specialist will just keep an eye on it. You will have regular checkup and heart scan every 1 to 5 years, depending on how narrow the valve is. If the narrowing is severe, which is usually seen in the echocardiogram, that your valve area will be less than 1 centimeter per square, and or if your heart function is reduced, then the specialist will recommend replacing the valve either surgically or using a catheter-based approach known as TAVI. TAVI is called transcatheter aortic valve implantation. Now, if you have time, you can explain all of this, but most likely you will not have that much time. As long as you mention this, that if the narrowing is severe, which means your valve area is now less than 1 centimeter, if your heart function is getting down, the specialist will recommend you to replace the valve. The valve can be replaced surgically, that means by operation, or nowadays there is a very new minimally invasive procedure which is called TAVI, which is a catheter-based approach. So they put a catheter through your arm or groin. The catheter goes into the heart, and then it can implant a artificial valve like on the top of the narrowed valve. Okay, so this is a very interesting procedure if any of you know. So TAVI replaced most of the aortic valve replacement in Australia at the moment. So most of the patient who needs aortic replacement, they will go for TAVI. Okay, so which means transcatheter aortic valve implantation. All they do is they put a catheter in, catheter goes into the heart, goes to the aortic area, and then it can just open up the narrowed valve and put a new valve there. The valve can be made of titanium, which is the mechanical prosthetic heart valve, or the valve can be biological, which is cow valve or pig valve. So any of them they can use. Then advise some lifestyle modifications. Say that along with this, lifestyle modification is always important for cardiovascular health. So make sure that you do exercise every day as tolerated, have healthy balanced diet, make sure you have an ideal body weight. Okay? And then just finish with 4R. So we haven't discussed what is 4R. 4R is a finishing statement, especially in a GP setting. So when you finish your management, the end should be 4R. So 4R include R for reading materials. So you give some reading materials for the patient. Then talk about when you want to review the patient. Are you going to refer the patient to someone? And what is the red flag? When the patient should go to hospital or come back to you. So you will say that you talk about the lifestyle and then say that I will give you some reading materials about this aortic stenosis. I will review you once the echocardiogram report is back. You already talked about referral. In the meantime, if you feel severe shortness of breath, if you're getting back-to-back loss of consciousness, if you have chest pain, which does not go away, please go to the emergency immediately. So red flags are, what's the red flag for these cardiovascular patients? Always chest pain, which doesn't go away. If they're getting worse, if they're having severe shortness of breath, all of these are red flag, and patient should go to emergency in that case. Okay? Make sense, guys? So not every aortic stenosis patient needs to be sent to the hospital. So you can decide who goes to hospital. If a patient has severe aortic stenosis, then we send them to cardiologist for a consideration of aortic valve replacement. But otherwise, these patients do not need to go to hospital straight away. Dr. Madhupriya, yes, we have a station just for physical examination alone also. Those are not like theory stations. This cardiology that we are doing, this is a theory station. Theory station, the physical examination is different, which is right now what we are doing. Physical examination finding from examiner. There are sole physical examination cages where you need to do the physical exam on a patient and find out the findings. Okay. And Dr. Vimbai, as a junior doctor, can we order echo ourselves, or we mention that it will be organized by supervisor or cardiologist? If you are a GP, you can, because they haven't mentioned that what kind of GP you are. If you are a junior GP or if you're a GP register under supervision, if they write something like that, like you are a GP under supervision, that is the time, yes, you need to talk to your supervisor to order a echocardiogram. But if they just say GP, then a GP is able to do echocardiogram. You don't need to send them to a cardiologist for it. These are outpatient echocardiogram, and a GP can organize them. There is no requirement of sending this patient to a cardiologist just to order a echocardiogram, because this will just delay the process. Okay. Everyone cool? You understood how to manage aortic stenosis? So for aortic stenosis GP setting, you will organize the ECG, organize echocardiogram, refer the patient to a cardiologist after the echo report if needed. If it is mild to moderate aortic stenosis, they will be managed just symptomatically. If they have any cardiovascular risk, we will manage it accordingly. If they have high blood pressure, we treat high blood pressure. If they have high cholesterol, we treat that. So any cardiovascular risk, we will just manage in that case. But if it is a severe stenosis, and severe means they have to fulfill this criteria, then you only send the patient to a cardiologist, and then the specialist will consider, most of the time they will consider this patient to have a catheter based TAVI. Okay. There is no medicine. So aortic stenosis has no medical management because you can't do anything to open up that stenosed valve. Okay, moving on to the next one. So the next case is prolonged QT syndrome. So we have got a 19-year-old girl comes to the emergency department because she fell unconscious 2 days ago and she was climbing up a mountain at that time. Your task is same. So this is a 19-year-old had a syncopal attack while climbing up a mountain. So these are the positive findings when you ask the history. Now remember, we are no longer discussing history. We are no longer discussing physical examination because it's done. You use the same format, and when you use the format, you will end up getting these positive findings. So you will find out that yes, patient was climbing a mountain, then suddenly lost her consciousness. This is not the first time. This happened 3 times so far. If you get that, yes, this is not the first time, then previous episodes also you need to ask in detail. So how many episodes so far? When did you get the first one? Can you describe what were you doing in those times? So you need to get a proper idea about the past episodes as well. Okay? Then, did you see any doctor for this? Did you have any investigations done? So get a proper idea about the previous episodes. Apart from loss of consciousness, there was no shortness of breath, no chest pain, no palpitation. There is a history of unknown heart disease in maternal uncle. So that's one of the important clues. Physical examination, no murmur. ECG showed prolonged Q2. So why we are not thinking about HOCM? Because HOCM sometimes can have a murmur. Okay, and HOCM ECG will not show prolonged QT. That's also important to know. Now, this case, usually they will provide you an ECG as well. So your task might be take history, ask for investigation from examiner, and then explain the ECG to the examiner. So you found in here, this ECG was given to you by the examiner when you asked for it. So when you asked for a ECG, you don't just think that what's in the ECG, you think about this patient. It's a 19-year-old having a loss of consciousness while climbing mountain. There is a family history of someone dying from an unknown heart disease. In your head, you already know that, well, it might be a HOCM, where I might get left ventricular hypertrophy. That's only thing I can get in ECG. Or it could be prolonged QT. So I will definitely look at QT in this patient. That's what you think in your head, right? Now, first of all, you need to know what is prolonged QT. So this is your QT interval. So QT interval starts from the Q. So that's the Q. So starting from the Q and end of the T wave, that's our QT interval. A normal QT interval is between 8 to 11 small square. If it is more than 11 small square, that is prolonged QT. Now you look at it. So lead 2 is usually the long lead. Long lead means you can see the whole, whereas others you can only see a small amount, right? So always look at the long lead first, especially if it is a syncope case or arrhythmia case. If it is a chest pain case, then you always look at the V1 to V6 first. So depending on the case, you will look in different areas at first. So first of all, in the lead 2, look at the rate and rhythm. So what is the rate you think, guys? So in our last class, we discussed about it. So we have got 1, 2, 3, 4, at least 4 large square. There is a little bit in here. You don't need to even mention that. It's fine. You don't need to be fully, like, an approximate heart rate will be enough for exam. So if it is 4, then how much will be the heart rate? Yes, so 75. So because there is 3 more small square, you can say that maybe 65. So if you are around it, you will be fine. So heart rate, let's say 75, then you check the rhythm. So check that whether all RR interval is in the same difference or same interval. Yes, they are regular. So we know about rate and rhythm. Then we go to the P wave. So how is the P wave? P wave is fine. It is present. Then we check the QRS complex. QRS, I can see that there is at least one small square, and that's normal. Then we look at ST. ST is in the same isoelectric line. So there is no ST elevation, no depression. Then we look at the T wave. T is normal as well. There is no inversion. So nothing is abnormal here. So what's the problem? Quickly look at the QT then. So we have got the Q here and end of T is here. So how much is small square? There is 5, another 5, 10, 11, 12, 13, 14, 15. So 15 small square is there. That means we can now say that yes, it is QT prolonged because more than 11 small square means it is prolonged QT. Okay, so that is the easiest way. I normally don't go to the millisecond because it can be confusing for you guys as well. So you don't need to mention how much it is in exam. As long as you can say that QT is prolonged, you are all good. And then you have found QT interval prolonged. Quickly check the V1, V6 and all other leads. So lead 1, you can see that there is a bit of T inversion in here. That's not pathognomic because to be pathognomic, T inversion should be at least in 2 contiguous leads. In one lead, if you get a T inversion, it's nothing. V2 normal, V3 normal, V4, V5, V6, all good. Lead 1, lead AVL, lead 2, 3, AVL. So quickly just see, because you already know that it is prolonged QT, but quickly look for any other abnormal finding. So then how to present your ECG? So if this is a case where you need to present your ECG to the examiner, how will you do that? Anyone wants to present it now? Dr. Anna, Dr. Wendy, any of you? Yeah, unmute yourself, Dr. Anna.
Dear examiner, I would like to present my patient's ECG. The rate is approximately 75 beats per minute. Rhyme is regular. P wave is normal. The width of QRS complex is normal. ST segment on isoelectric line and T wave is normal, no inversion, but a QT interval is prolonged. So probably my patient is suffering from prolonged QT syndrome.
Brilliant. Thank you, Dr. Anna. So yes, if you say in this way, this is completely fine as long as you are talking about rate, rhythm, how is the P wave, how is the QRS, how is the ST, T wave, and QT interval. That's all that they would like to know. Very good. Thank you. So now we know this is a prolonged QT syndrome. How we are going to explain it? So we'll say, Sarah, most likely you have a condition called prolonged QT syndrome. Do you know what it is? No, doctor. Well, let me explain. So if you already have they will give you a ECG and you can show it to the patient. So this is the electrocardiogram of your heart, which is the recording of the electrical activity of the heart. Let me draw a picture for your better understanding. So you can quickly draw a picture. So this is your heart. every heartbeat starts with an electrical signal. So every heartbeat starts with an electrical signal that tells your heart to squeeze and pump blood. After that, the heart needs a brief pause to reset before the next beat, like recharging a battery. This reset time is what we call QT interval in the ECG. So it's a very, very good way of explaining that what is prolonged QT. So you know that the heartbeats are like that. So every heartbeat will start with the electrical signal, start from the S node, goes to the AV node, and then through the bundle of His Purkinje fibers, it goes to the rest of the heart and it pumps the blood, right? After that pump, so once a systole happened, heart takes this brief pause to reset before the next beat. And that duration, that the amount of time the heart take as a brief pause is recorded in the ECG as a QT interval. So that's what we're explaining. Every heartbeat starts with an electrical signal that tells your heart to squeeze and pump blood. After that, heart needs a brief pause to reset before the next beat. This reset time is what we call QT interval in the ECG. In your case, this reset part of each heartbeat is taking longer than normal, which can cause the heart to beat in a dangerous, irregular way. That can result in impaired blood pumping, causing the frequent collapse that you're having. So when this reset time is longer, then heart start beating abnormally. And that will cause impaired blood supply to the whole body, including the brain. And if brain doesn't get enough blood, they start to get this collapse. Sometimes, so always when you explain something this much complicated, always ask the patient that, are you understanding, Sarah? Do you have any questions? No, doctor. Well, then these conditions sometimes run in the family. Sometimes it can be also due to some medication, dehydration, or salt and water imbalance. Although it can be due to other differential diagnoses as well. So give some differential and say why it is unlikely. Unfortunately, this condition can sometimes cause serious consequence. That's why I would like to admit you to the hospital. So this is a ED setting and call for a heart specialist to review you. Please do not worry, you are in safe hands and we will do our best to manage your condition. Okay, so you can say in this way that unfortunately, this condition can sometimes cause serious consequence. That's why I would like to admit you to the hospital. I will call my senior and also a heart specialist will come and review you. Please do not be stressed or please do not be alarmed. You are in safe hands. We will do our best to manage your condition. The specialist might do few investigations like full blood examination, your salt and mineral balance, so urea electrolyte creatinine, blood sugar level, and an echocardiogram. Every one of them has a reason why we are doing it. Full blood examination to rule out whether the patient might have any pallor or anemia. Urea electrolyte creatinine is the most important because sometimes hypokalemia, hypomagnesemia, or any electrolyte imbalance can cause this. Low blood sugar can be a cause of syncope, especially patient was climbing the mountain. So this is important to rule out. And echocardiogram is important to rule out any structural heart defect. Okay, so the specialist might do few investigations like full blood count, your urea electrolyte creatinine to check for any salt and mineral imbalance, blood sugar level, and the echocardiogram, which is nothing but a scan of your heart. As part of the management, lifestyle modification is really important. So please avoid any medication that can prolong this interval. I will give you a list of medication which can increase this QT. So before any doctor starts you with a medication, always let them know that your QT interval is prolonged. Avoid intense emotional or physical stress because that can cause your heart to beat more abnormally. Stay well hydrated and maintain your salt and mineral balance. Avoid loud alarms or sudden noise. So these are important part of lifestyle modification for patient who suffers from this QT prolongation. Because even a sudden noise or loud alarm can set off their heart irregularly. They can start beating chaotically, and it can cause a lot of problem. Okay, so these are the lifestyle advice. As part of the medication, a specialist might start you with a medication called beta blocker, which can protect your heart from going into dangerous rhythms by slowing it down, especially in response to a stress, exercise, or fight and flight hormone, which is the adrenaline hormone. If you continue to have symptoms or have ongoing collapse, the specialist might consider a pacemaker to prevent the heart rate from going too low. In some high-risk cases, a small device called implantable cardioverter defibrillator may be placed under the skin to shock the heart back to normal if needed. Since this condition can be inherited, I will ask a genetic specialist to check if you have any genetic mutation causing this. If we find one, we will also arrange genetic counseling to help you and your family understand it and decide if other family members should be tested as well. And lastly, finish with 4R. So to give you a proper idea that how we manage prolonged QT is a combination of lifestyle modification. Medication is usually the first line, so beta blocker will be the first line treatment to make sure that the heart doesn't go too high. Sometimes these kind of patients, when they are under stress or exercise, their heart rate can become too much, and too much heart rate is also a problem for this patient. So we give the beta blocker to keep it down. But if the patient's heart rate is going too low, like less than 35, in that patient, they will get more and more collapse. In that case, sometimes a pacemaker might be helpful to keep the heart rate from going too low. If a patient is in very severe stage, constantly having dizziness, even with beta blocker, pacemaker, still patient is going, like heart rate is going too low, then the last option is this ICD, because ICD is an implantable defibrillator. So if the heart goes to cardiac arrest, then this defibrillator, which is already in situ, it can shock the heart to bring it back normal. Okay, so that's the step-by-step management for QT interval. It's very important to mention about this genetic pattern of QT syndrome. So you will need to arrange a genetic counselor and a genetic specialist who can test for any genetic mutation for this patient, and if it is positive, then the whole family members needs to be tested, at least the first degree relatives. Okay, make sense, everyone? No. If the heart rate is very low, like if the heart rate, let's say, going to 35, then you can't give the beta blockers. No requirement of atropine in this patient. Dr. Shuparna, which sequence we are talking about? You can unmute and ask.
Hello, sir. How
Yeah,
are you?
I'm good,
I
thank
am
you.
actually okay. I am actually confused about how I explain patient after I collect information from my examiner, then I have to explain my diagnosis, the investigations, and treatment approach to patient.
Yes, yes, that's right. So after you collect information from, first you take history from the patient. That gives you a bit of an understanding about the case. And then you get physical examination finding from examiner. Some cases you might even get a ECG. So all these informations will lead you to the diagnosis. After that, you come back to the, so after your physical exam or the investigation, you come back to the patient and you give your explanation. So this explanation will be to the patient itself.
Okay, okay. Thank you.
Thank you. So Dr. Aryan, very good question. So before, because this is AMC clinical exam and they don't want to go that much detail, I haven't mentioned this electrophysiological study. Before we go for pacemaker, so these are the part of cardiologist. We as a junior doctor, you guys don't need to go in that much detail. So ideally what will happen that cardiologists will try the beta blocker. If beta blocker does not help, then cardiologist send this patient to a electrophysiological like a specialist. So the EP specialist then will do a proper check, including a Holter and also do the proper electrophysiological study. And based on the electrophysiological study, they will decide that whether this patient needs a pacemaker. Okay, so that happens, but we don't need to go into that detail. Holter is not must in here because we already found that this patient has got prolonged QT. Holter can help us to know that how low the heart rate can go or how high the heart rate can go. That it will help. So we can always do that, but for this particular case, it's no longer needed. If you have some time, you can add all of this. You can say that I'm going to send you for a, so one that the GP can also organize this because this is a hospital setting. You can't normally, you would not organize that. Some hospitals do that. So you can put the patient on a 7 days halter to see that if you can find out any other arrhythmia, you can find out how bad the brady goes. So we can do all of this. But do we want to make it that complicated in the exam? Not really. So basically all they will need to know that, do you know about the medication? Yes, beta blocker. Do you know what else we can do? Yes, the next is pacemaker, next is ICD. If any of you want to add a little bit more, especially about sending to the electrophysiological study, talking about Holter, we can definitely do that. It's totally fine. And normally we would do it in our real life. Do we need to give any advice regarding occupation? We have already given advice in here, and that advice will include anything related to occupation. So if their occupation involves a very high physical stress or emotional stress, then yes, they need to come out of it. If they are working in an industry where there is a lot of sudden noise, they need to come out of it. We don't need to specifically say those because in exam we will not have that much time. Or even if you want to finish what we have written in here, it will be very difficult. So I always keep it as simple and as shortcut as possible because you can't finish all this in 8 minutes. It's very, very difficult to finish. Okay. So even from what we have written in here, if the task is 4 tasks, history, ECG, and diagnosis explanation, you will not be able to say all of this. You need to cut it short sometimes. So start doing the role play. You will find out that even what we have written in here, it is too much for you. So then you will need to find out that what else I can cut off. Like in the lifestyle modification, you can make this 4th thing in one sentence, right? So you can say that first, we would like you to follow lifestyle modifications, so avoid medications, intense emotional or physical stress, stay well hydrated, and avoid any loud noise or alarms. See that I just finished in one sentence. If I want, I can prolong it. If I have time, I will prolong it. But if I don't have time, I will just make it very simple in one sentence. And that what you also need to understand, that how much you can say, how much you can manage in that time. That comes with a lot of role plays. Without role plays, you will not know how much you are finishing. Okay? So when you're doing the role play, do it in different ways. So first, do it as history, physical examination, investigation from examiner, diagnosis, and DD. That's it. In another task, do it as history, investigation, explanation with management. So do it in multiple ways so that in exam, if tasks are different, you know how to do it. Because what happens when you do the role play, all of you do it like history, physical exam, investigation, diagnosis, management. You do all of it. But in exam, you might not have all of it. So you need to know that how to do it in the real exam. Okay? So try to do the role play in different ways, removing the task, making the task either longer or shorter. See how you are managing the time. There is no clock in the room, so you will never know how much time you have. That's the problem. That's been always a problem, but that comes with a lot of role plays. So we discussed about this, Anna, in our first class, where we discussed the introduction to AMC clinical, that how it happens. So if you haven't done that class, or any of you, if you haven't done our AMC introduction class, which was the first trial class we have taken, there is a vital part to go through. So what happens is that once your time is up, you get a bell. And if you hear the bell, that means your time is up. You will need to stop there, get out of that room, and go to your next task. Doesn't matter if you haven't finished it or not. Okay. Moving on to our next case, postural hypotension, very, very important for exam. So two ways it can come. A middle-aged woman comes with dizziness for the last several days. So postural hypotension not necessarily will come to you with syncope. It can only come as dizziness. A 65-year-old man comes to you because he had a fall. So it can come as a fall, come as loss of consciousness, come as dizziness. So all of these are same cluster. Remember, dizziness, fall, or loss of consciousness, more or less the same history. So how we're going to start the history in here? So first of all, you introduce yourself, reassure the patient, ask about hemodynamic stability, and then your HOPC is dizziness in here, right? So for dizziness, what we normally ask, so now remember, this case is more about dizziness, not loss of consciousness. So because it is dizziness, we are not able to ask about pre-syncope, syncope, post-syncope, because patient did not lose consciousness. Okay, so if they did not lose consciousness, like this case, then the case will become slightly different. So can you tell me a little bit more about this dizziness? So patient will give you some idea. You need to find out that when did it start? Okay, first of all, when did it start? How many episodes so far? Even before that, we need to know that if this dizziness is lightheadedness or vertigo. So can you tell me a little bit more about this dizziness? Patient will give you some idea. We will need to confirm, do you feel lightheaded and giddy, or is the room spinning around you? This is a super important thing to know, because if it is room spinning, it becomes a vertigo case. There is a case with recent physical examination on vertigo, which we will discuss in our physical exam class. But it's important to differentiate between these, because vertigo has different approach lightheadedness, giddiness has different approach. So do you feel lightheaded and giddy, or is the room spinning around you, or you are spinning around the room? So if patient in this case will say, no, nothing is spinning, I feel just giddy. Well, then we know that it is just giddiness or dizziness. So when did it start? How many episodes so far? Can you explain a few of the recent episodes? What were you doing during those times? So getting an understanding about those episodes will give you a proper idea that what context is there. Is it happening mainly when patient changing position? Is it happening because patient is losing control because they are weak in their lower leg? Maybe patient had a stroke. So these things will give us an idea that what's causing the fall or what's causing the dizziness. Okay, so find out that what exactly happened in this recent episode. Did you fall or lose consciousness at any time? So that's our dizziness question. In here, patient will say, no, I had a fall, but I did not lose consciousness yet. So this is no longer the pre-syncope, syncope, post-syncope questions anymore. But your differential diagnosis is same. So in the differential diagnosis, we have CNS causes. So ask all the CNS question: any headache, blurring of vision, any weakness, any difficulty with your speech or swallowing. Then CNS cause includes epilepsy, any jerking movement like seizure, convulsion. If yes, then you can ask about did you bite your tongue and all of them. It's just one question for epilepsy, any jerking movement. Any recent head injury, that's for head injury or trauma. For infection, any fever, nausea, vomiting, any rash, neck stiffness. For brain tumor, because brain tumor can also come as dizziness or giddiness. So any early morning headache, nausea, vomiting. So you can ask that, any early morning nausea, vomiting, headache. Any difficulty with keeping balance, because these patients can get ataxia. So these are all important differential diagnoses for dizziness in related to CNS. So first you asked about stroke questions, then epilepsy, then head injury, then meningitis, and then brain tumor. After that, we have got CVS questions, which is same. In the CVS question, you can add any swelling of your foot or ankle, then others. So for hypoglycemia, does it happen mainly when you skip your meal? Any history of diabetes or high blood sugar? For vasovagal, does it happen when you stand or sit for a long time or do heavy exertional activities, mainly in the hot, sunny weather? Very good question. Then we go to postural hypotension. Do you feel dizzy when you change your position, like standing for a sitting or lying position? Patient will say yes. So now you will understand that how we ask detail. So in this case, when you say, do you feel dizzy when you change your position, especially standing from sitting or lying position? Patient say yes. Then you say that postural hypotension has a lot of causes. Could be due to like dehydration, could be due to any infection. So lots of other causes, like even Parkinson patient can come as postural hypotension. Dementia patient can come in that way. So ask about all of them. So any recent vomiting, diarrhea, any fever or flu-like illness. So these two is the common cause. Fever or flu-like illness, sepsis or infection can cause postural drop. Vomiting, diarrhea that causes loss of fluid, causing hypovolemia, causing dehydration, causing the dizziness. Okay. Any dizziness after eating. Postural hypotension patient can have postprandial hypotension. That means after eating, their blood pressure can fall. So that's a very common association of patient who has postural hypotension. So that's what we call as postprandial hypotension. Any increased frequency or urgency of urination? Why we ask it? There is a question where patient came with fall Nothing else is positive. If you ask about that, are you having increased frequency or urgency of urination? Then the patient say yes. That's UTI. So it's very uncommon cause, but again, because this comes in exam, you need to know them. Yes, and also sometimes it can be micturition syncope. So both of them, for that reason, we are asking that any increased frequency or urgency of urination, and that can be positive in this patient because UTI can be a cause of postural drop. Any shaky hands or difficulty with walking. So Parkinson patient commonly have postural hypotension. So that's why we're asking shaky hand is for tremor and difficulty with walking is related to the Parkinson gait. Any loss of memories? Is it worse first thing in the morning? So loss of memories, especially some of the Parkinson patient can also get dementia, or even some of the dementia patient can have postural drop. Is it worse first thing in the morning? Patient whose postural hypotension is worse in the first thing in the morning. That means when they get up in the morning, they change their position. If that is the worst, then we will be looking towards any autonomic failure. Okay, so we'll discuss about this later on. Just remember these questions that we are asking. So do not forget at least the recent vomiting, diarrhea, fever, flu-like illness, dizziness after eating. Ask about UTI question, ask about Parkinson question, ask about any loss of memories, and is it worse first thing in the morning? Okay, so these will be the main questions for postural hypotension because we need to know the cause of postural hypotension, not just that you have a postural hypotension, because postural hypotension is a diagnosis, but there is a cause and you need to find the cause to treat this condition. Okay. So after that, ask about anemia. So same, do you feel tired these days? Any bleeding from anywhere? Stress is important always. Past medical history. Now, there is a case or there is an important cause of postural hypotension, which is diabetic autoneuropathy. So many times, if it is an uncontrolled diabetes mellitus, it can complicate as a diabetic autoneuropathy. That means the autonomic nervous system does not work in that patient. And how our autonomic nervous system actually works? Our autonomic nervous system works like this. So the system is designed like this, like when you stand up suddenly from sitting or lying position, when you stand up, the blood is actually in the periphery, right? So blood needs to go quickly to the brain. So what our autonomic system is designed that the sympathetic nerve will cause vasospasm. And with the vasospasm, blood will rush to the blood. And that's why a normal person should not feel dizzy when they change their position. But patient who has autonomic failure, this sympathetic nervous system do not work for them. So when they stand suddenly, their sympathetic nervous system does not squeeze the artery that hard, or it takes some time to do that. And that's why when they suddenly stand, their blood pressure drops. Does it make sense, guys? Okay, so diabetes, patient with autonomic neuropathy, this autonomic nervous system will be failed. So it's not for well-controlled diabetes, but for patient who has uncontrolled diabetes, they will have this problem. So that's why if it is a diabetic patient, we will need to ask each and everything about it. And there will be a case where we discuss all the questions, you will see. And hypertension. If a patient has uncontrolled hypertension, that can cause postural hypotension sometimes. So it's very important to find out whether the patient is diabetic, whether the patient has high blood pressure. Then SADMA, smoking, alcohol, medication history should be in detail, because one of the case in the exam is polypharmacy. So patient is taking multiple medication, especially ACE inhibitor, diuretics and all, and that has caused like significant loss of volume because they're taking like an increased amount of diuretics, ACE inhibitors, so their fluid volume is low and they're feeling dizzy. So medication history is must. And lastly, finish with any family history of heart condition. Okay, so for postural hypotension, it's a bit different, but as you understand that the history or the differential diagnosis is more or less same. Just in the CNS, we have added brain tumor, CVS, hypoglycemia, vasovagal, these are all same. Just in the postural hypotension, we have to add few more questions. That's it. So in this case, the positive point was patient feels dizzy when standing from sitting or lying position. Patient has diabetes, but it's well controlled, taking metformin, aspirin, diuretics, ACE inhibitors. Pretty important. Complaining of heartburn, loose stool, and in the physical examination, only postural drop. That's all that we have found in this patient. So we have found a patient who has postural hypotension, and we can see he's on diuretics and ACE inhibitor. He's diabetic, but it's well controlled, so unlikely that's causing that. There are few other cases. One case was patient was sitting in a church for, let's say, hours. While standing from sitting position, patient collapsed. So that's another. And another was medication related. Patient was taking risperidone for psychiatric problem and having dizziness. Risperidone is a common medication to cause postural hypotension. So the first case where patient was coming to us with dizziness, how we are going to explain it? So let's see. So most likely you have a condition called orthostatic or postural hypotension. Do you know what it is? No, doctor. Well, this occurs when your blood pressure drops when you stand up too quickly. As a result of that, you feel dizzy, lightheaded, or even sometimes you can faint for a short time. So very simple way of explaining. So this occurs when your blood pressure drops when you stand up too quickly. If time permits, so if you think that you can finish, then you can explain the pathophysiology. Otherwise, don't bother. When you stand up, gravity pulls blood down to your legs. Normally, your body quickly adjusts by tightening blood pipes and increasing your heartbeat to keep the blood flowing to your brain. As I say that gravity will pull down all the blood to the legs, but sympathetic system will cause tightening of the blood vessel, and it will send blood to the brain quickly. But if your body does not adjust this fast enough, your brain gets less blood for a moment, causing these dizzy episodes. It could be due to many reasons, like if you are dehydrated due to not taking enough water, due to severe vomiting, diarrhea, could be due to infection, strenuous exercise. But in your case, most likely it is the multiple blood pressure lowering medication that you have been taking. So if you can explain that you are taking two blood pressure lowering medication, one is ramipril, let's say, and another is thiazide diuretics. Both of these medication can reduce your blood volume. And if your blood volume is already low, your brain already will be not getting enough blood and oxygen, and that's why most likely you are getting these episodes. Also, as you are diabetic, it could be due to some nerve damage where the system that helps to push the blood to your brain does not work properly, called autonomic failure. Uncontrolled diabetes can cause autonomic neuropathy, which can manifest as heartburn, bloating, diarrhea, difficulty in urination, and sexual dysfunction, along with dizziness with change of position. but your blood sugar is well controlled, so it is very less likely. It can also happen in Parkinson patient, but you do not have any symptoms related to that. See that we are explaining all the causes of postural hypotension. Many times the question will ask you that explain the diagnosis with reason. This is how we explain diagnosis with reason. And if it is a postural hypotension case, we are supposed to mention these causes, that what's causing this. This type of dizziness or fall can be due to other reasons. So if you have some time, you can give all other differential as well. As part of the management, I'm going to organize some basic investigations like full blood count to rule out any anemia or lack of blood count, inflammatory marker, your salt and mineral balance, your kidney function, blood sugar level, thyroid function, and then ECG. Hypothyroid can come as dizziness also. And ECG to rule out any cardiac problem. Also, to rule out any autonomic failure or nerve damage, I will arrange a 24-hour blood pressure monitor to check your blood pressure at night. Now, this is a bit a specialist level discussion, but this is what we do. And if you can say these things, examiner mind will be blown away that how come a junior doctor knows all of this. So what we do that in autonomic failure, you do understand what I'm meaning by autonomic failure is the sympathetic nervous system, which is supposed to push the blood, is no longer working properly. And that can be due to causes. Diabetes can cause this, Parkinson can cause this, okay? So, and even age, that old patient, even age can be a factor. So autonomic failure, we do this 24-hour blood pressure monitor to check the blood pressure at night. The reason is that in patient who has autonomic failure, ideally at night, every normal person's blood pressure should drop. That is called nocturnal dipping. So if I show you, so why does nocturnal dipping occurs? So at night, you are no longer worried about everything that's happening at your life. So your sympathetic nervous system, which is fight and flight, slows down. This leads to vasodilation, and that causes reduction of blood pressure, reduction of heart rate. So you become calm and quiet, right? That's how sleeping works. So at night, ideally, your blood pressure should drop. But in patient with autonomic failure, their blood pressure does not drop at night also. Okay? Because at night their blood pressure does not drop, they get this natriuresis, which means that they get up multiple times at night and they keep on having urination every 2 to 3 hours. What they're doing, due to this natriuresis, your body is trying to get rid of the excess fluid to lower down the blood pressure. On the way to do that, what happens is that in the morning, they are already volume depleted. So the first thing in the morning, they have been urinating the whole night, and when they get up after waking up, they usually get the first hit, the worst hit. Okay? Does it make sense? So in patient with autonomic failure, they actually get nocturnal hypertension. So their blood pressure stays high. And if it is high like this, the body will try to reduce the blood pressure. And how it can do? It can reduce the blood pressure by reducing the blood or fluid volume. So it asks you to get up multiple times at night to pass urine, which is the natriuresis. And then throughout the night, you're doing that, and you are already volume depleted for that. So first thing in the morning, when you get up again, you feel really dizzy, or even sometimes you fall. So autonomic failure patients, this is one of the way to know. So we can always put the patient on a 24-hour blood pressure monitor to check whether their blood pressure is dropping at night. If all the investigations come out normal, then we can be sure that it's due to the medication only. In that case, we will either reduce the dose or change the medication accordingly. Okay, so if it is medication related only, then we can just reduce or change it. Also, it is important to follow some general measures to reduce this dizziness. So it depends on the time that you have. You don't need to say all of this. So avoid a hot environment when possible. Do not sit or stand in the same position for too long. Move around. Stand up slowly, especially when you're standing from lying or sitting. You can also tense your leg muscles or cross your legs when sitting, which will help to push the blood back to the brain. Avoid alcohol, especially in the morning. Drink more fluid in the morning and throughout the first half of the day. You can wear supportive belt around your waist, which can help push blood to your heart. Join exercise program to improve your circulation. And there is a half-minute rule. When you get up in the morning, sit up slowly. Stay for 30 seconds. Put the legs over the side of the bed for 30 seconds and slowly get up to prevent any dizziness. So I understand that this might be quite a lot of discussion, but sometimes there will be like this history so you just need to take history and you need to give diagnosis with reason. That's most likely the case would be. In diagnosis with reason, you need to explain postural hypotension, how it is occurring. That means even the pathophysiology. You need to explain all the causes one by one. And as part of the investigation, first rule out anything abnormal in the blood, like electrolyte imbalance causing this. Then do a ECG to rule out heart problem, and do this 24-hour blood pressure monitor to rule out autonomic failure. If everything comes out normal, then it is just likely the medication causing that. Okay? Does it make sense, guys? So just a quick discussion about orthostatic hypotension. So orthostatic hypotension is, you can't diagnose someone as orthostatic hypotension based on a single reading. Okay, so if you suspect orthostatic hypotension, you need to measure the supine blood pressure and heart rate after 5 minutes of quiet rest. Remeasure the blood pressure and heart rate immediately on a standing. So you can do it in sitting or lying position. So let's say patient is on lying position, then patient needs to take 5-minute rest. After 5-minute rest, you check their blood pressure and heart rate. Then you record it somewhere and then ask the patient to stand up. Then you remeasure their blood pressure and pulse. Orthostatic hypotension is diagnosed if there is a fall of systolic blood pressure of at least 20 millimeter or diastolic 10 millimeter within 3 minutes of standing. Let's say on the supine, patient's blood pressure was 140/90. And on a standing position, it's now 110/80. So any of them will be fine. So 140 to 110 means this is already more than 20. So if systolic drops more than 20 or diastolic drops more than 10, that's your diagnosis of orthostatic hypotension. If orthostatic hypotension is present, lack of reflex increase in heart rate may indicate autonomic failure. This is another interesting thing, that normally what should happen when your blood pressure drops like this, your heart will sense that and your heart will start pumping more so that it can send blood to your brain and everywhere. So normally you are supposed to see that at least patient is getting a little bit of increased heart rate from here. So when they stand. Okay, but that's usually less than 30 beat per minute increase. So When they stand like this, the body will try to increase the heart rate, but it will not be super high. So it will be usually less than 30-minute increase of heart rate between the supine and standing. That is the quickest way to know that whether there is any autonomic problem. Yes, the reflex tachycardia. So if you see that when patient stand from supine position, their blood pressure dropped, but their heart rate did not increase. That might also indicate that it is an autonomic failure. And that is the quickest way to even think that this patient might be having some autonomic problem. Then we quickly look whether this patient is diabetic, whether this patient having age-related problem, whether this patient has Parkinson. So we start looking on those things. Okay? So autonomic nervous system dysfunction, the main two cause is Parkinson and diabetes. There is another condition called multiple system atrophy. You don't need to know that. Common cause is volume depletion, so dehydration, blood loss, and there are lots of medications, including antihypertensive, vasodilators, even antidepressant can cause this. Okay? Prolonged bed rest, cardiac cause like heart failure patient can have this problem, bradyarrhythmia, tachyarrhythmias, endocrine cause like Addison's disease patient can have postural hypotension, diabetes, hypothyroidism, that's why we did the THIs, and even aging can cause this. I'm doing it quickly because you can read it in your own time. So summary of assessment. So when we get a patient with orthostatic hypotension, the first thing that we do is we confirm that yes, this patient has orthostatic hypotension. The second thing is this patient taking any medication which can cause postural drop? That's the second. Rule out any acute causes, which means whether the patient has got vomiting, diarrhea, any excessive bleeding, maybe patient had a recent surgery. So find out any acute cause. And then you find out whether there is any autonomic failure, which is easy. If there is no reflex tachycardia when patient is stand up, that's the time we think of autonomic failure. And then you can arrange that 24-hour blood pressure monitor to find out about the nocturnal hypertension. Treatment. So the treatment is finding out the cause and the specific measures that I talked about. That means the lifestyle modification. If the medication is the cause, you reduce the dose or change the medication. Now, if you haven't found out any causes and patient having significant drop of blood pressure, the option is to send the patient to an endocrinologist who can start the patient with fludrocortisone, which is a synthetic mineralocorticoid. And you know that mineralocorticoid can retain water. So it can expand the plasma volume and it can help the patient with this postural drop. Okay, but it can be only started by a specialist, not by any others. All clear, guys, about orthostatic hypotension? I'm sure you will never forget it, and I'm sure you did not go in this much detail ever about it. The thing is that if you know something, you should know it clearly. Knowing it half doesn't actually give you anything. So better to know it perfectly than knowing it just half. Okay, moving on to our next case, and I think that will be our last case. So vasovagal syncope. An 18-year-old girl fainted during marathon running during annual sports. Now fully recovered, mother came to consult you about it. Take history, physical examination, tell possible causes. Let's say we rule out this mother. So let's say 18-year-old girl came. The positive point in the history, so she was running a marathon and then she fainted. So girl fainted during running marathon. It's a hot, sunny day. And on the top of it, she skipped her breakfast. When you checked her blood sugar, it is 3.6 millimole per liter. If it is less than 4 millimole per liter, it is called hypoglycemia. So you have got a hypoglycemia child as well. So sometimes in exam, multiple things can be there. This is a case where there are sometimes 2 or 3 causes are given. The same patient, if you ask about her period, you will find out she is also having heavy bleeding in her period, which is menorrhagia. And if they give you physical examination, they can say that pallor positive, which means they are also thinking of iron deficiency anemia related to menorrhagia in that child or in that girl. So sometimes multiple things can be there. Like this patient had a vasovagal syncope because she was running in a hot sunny day. Then she skipped breakfast, caused hypoglycemia. On the top of that, she already have anemia. So all 3 causes then you will need to discuss. So in exam, if you just get one finding, don't just be very happy and stop thinking about everything. You might get multiple causes in a patient. Okay. So you will explain that the temporary loss of consciousness that you had today is called syncope. There are many reasons for it, but in your case, there are 2 possibilities. One is vasovagal syncope. In this condition, in response to certain triggers, such as overexerting in hot, sunny weather, can stimulate a nerve in our body, causing pulling of the blood in our legs. As a result of that, the heart does not get enough blood, so it cannot pump blood to your brain, causing this sudden loss of consciousness. So what happens in vasovagal is that in response to certain trigger can be overexertion, can be pain, fear, any of those, it can stimulate the vagus nerve. And you know that vagus nerve causes vasodilation, right? So it causes peripheral pulling of blood. So blood draws into the legs. So definitely the heart will not get enough blood, and then the brain will also not get any. That causes this syncope. Very nice and easy way of explaining. Please do not stress. It is a very common cause of fainting, and I can assure you that there is nothing wrong with your heart or brain. Very important to say this line because this kind of patients will be very anxious that they lost their consciousness. They might have got a heart attack or maybe got a stroke. Another condition that can precipitate this attack is hypoglycemia or low blood sugar. As you skipped breakfast and then you went for running a marathon, this most likely led to your low blood sugar. Also, when we measured your blood sugar, we found it is low. So I'm going to give you a sugar drink, or I'm going to give you some jelly beans to take, and that way your blood sugar should come up. So if anytime you find out in exam that patient is having low blood sugar, which is less than 4, offer a glucose drink or jelly beans, like one teaspoon of honey, or even a slice of sandwich, anything like that, you can offer. Okay. And lastly, give all other differential diagnosis of syncope in this patient. Clear? If you get that this patient also has got that menorrhagia, then you need to talk about that most likely you also have anemia, which is lack of blood count, and that's most likely due to your increased bleeding in your period. So I'm going to send you for a blood test, which is blood count and iron status, to find out if you're low in iron. It's not heat stroke. Heat stroke has different kind of presentation. Okay, there you will see that their body temperature goes really high. So ideally, we would not say that this is this is heat stroke. And lots of other features are there. They can get fainting, but other than that, lots of other things can happen. They can have nausea, vomiting, fast breathing, muscle spasms, So a lot of things can be associated with that patient. Okay, so that's all about the syncope. We still have another case, which is a recurrent fall case. Let me see. We would not be able to finish this anyway. Let me finish this case because this case is very important. Without this case, this syncope cluster is not finished. So we will need to take another cardiovascular class. So there will be a class 3 on CVS because still we have palpitation cluster left and hypertension cluster left. So what we are going to do that instead of the cardiology role play session next week or next class, we will do a cardiology class 3. We finish the cluster and then we do a cardiology role play. Okay. So let's continue this recurrent fall case and then we can finish. So recurrent fall is a very important case in exam. And it's more or less related to the postural hypotension case that we have just done. So the history is pretty much same. So patient will come to you, usually elderly patient with recurrent fall. So recurrent fall, your main differential diagnosis should be polypharmacy, postural hypotension, can be due to any of them, vasovagal, CNS, CVS, it could be endocrine causes like hypoglycemia, or even diabetic complication like diabetic retinopathy because they will not be able to see, so they can easily fall. Diabetic neuropathy, especially diabetic peripheral neuropathy patient, they can't feel anything on their foot or sole. So they don't know where they're stepping on. So they can easily fall because of that. Electrolyte abnormality, vomiting, diarrhea, anemia, and any recurrent fall, we always add these 3 things. What's their home situation? So we need to find out whether there is a loose carpet at their home, whether they have like lack of lighting, so poor lighting in their home. So those things needs to be checked. Vision and hearing, most of the elderly patient will have problem in there, so that can also be a cause. And joint problem, many elderly patient will have significant osteoarthritis, some might had a stroke and they are in rehab. So even because of musculoskeletal problem, they can end up having recurrent fall. So all these questions you need to find out in your history. So in the history, the same how you start, so reassure, introduction, and then start with the fall question. The fall question is same. So how many episodes so far? What were you doing in each of the time? So same questions. And in the fall question, you can ask what happened before fall, during fall, and after fall. So same question of pre-syncope, syncope, and post-syncope. Then you come to the differential. So CVS, CNS, same history. Postural, also the same questions. Anemia. So your differential diagnosis questions are same. When you come to the past medical history, you will find out that patient has diabetes. Not always. Don't just think that, well, I haven't got diabetes in my exam. I will not say any other cause. So it can be anything in exam, but let's say that this patient has got positive diabetes. So you need to ask how long you are diabetic. Is it well controlled? What's your blood sugar looks like? So do you take your blood sugar every day? What's your fasting blood sugar? When was the last time you did your blood test? So how was your HbA1c? Are you regular with your specialist? Do you take any medication? If yes, what medications you take? Do you take it every day? And find out that whether they are taking any insulin or what are the medications they are taking. Any problem with your vision to rule out diabetic retinopathy? Any numbness, tingling sensation in your foot or in your fingers? So numbness, tingling for peripheral neuropathy. In this patient, you will find out that their diabetes is not well controlled. So it's uncontrolled diabetes. They also will say that I can't see properly, so they will have vision problem, and they will also say numbness, tingling as well. So all of these will be positive in this case. But don't just get very happy and stop asking question, because you always can get multiple problem in one case. So ask about their SADMA, especially medication, and finish with home situation. So how is your home? Who do you live with at home? Do you have enough support? Any loose carpet? Any problem with lighting? Do you have any joint pain? Any problem with walking or keeping balance? Okay, so these are your recurrent fall question. Once you have done that, you come to the physical exam. In physical examination, general appearance like before, vitals, BMI. In this case, patient specifically mentioned that he can't see. So you should definitely check the eye, right? So you will say that I would like to examine the eye. First, I would like to know about visual acuity, visual field. I would also do eye movement and also a fundoscopy. So visual acuity, you will find out patient has like low visual acuity. Visual field is important because if it is a brain tumor, patient will have, some patients can have homonymous hemianopia, which can suggest that this patient might have a pituitary tumor. So we're taking the visual field and fundoscopy also for raised ICP. If it is hypertensive retinopathy, patient will get papilloedema. If it is raised ICP, patient will get papilloedema. Okay, so fundoscopy is super important to find that out. And also on fundoscopy, you will find out the findings of diabetic retinopathies. Now, what happens that they don't give you diabetic retinopathy fundoscopy picture in exam. So they might just say that yes, you have found fundoscopic findings positive for diabetic retinopathy. That's what they will say. But you need to mention that why you want to do it. So first, I would like to check the eye for visual acuity and visual field, please. And then I would also do a fundoscopy to rule out diabetic retinopathy or any papilloedema. After the eye, then quickly check the CVS, do the CNS. In CNS, you will say, I would like to do full central nervous system examination, including both upper limb and lower limb neurology. But specifically, I would like to focus on any sign of peripheral neuropathy in this patient. Direct questions, especially like this, will lead the examiner understand that you know what you are doing, because you have got these positive findings in your history, right? So you are definitely looking for diabetic retinopathy. You are definitely looking for diabetic peripheral neuropathy in this patient. And you will get positive finding. Yes, there is a glob and stalking, loss of sensation in this patient. Quickly check the musculoskeletal exam for any joint pain or joint tenderness. And office test, blood sugar, urine dipstick. Okay, so that is the recurrent fall physical examination, general appearance, vitals and BMI. Then ask about the eye, CVS, CNS, musculoskeletal. The positive point in this patient was 3 episodes of fall. Patient has been diabetic for 10 years. Numbness, tingling positive. Vision problem is positive. Knee joint pain. Patient has a past history of a stroke and having physiotherapy for that. Physical examination, fundoscopy shows retinopathy features. And when you do the examination, you get peripheral neuropathy. And you found blood sugar is super high, 16, right? So all of this goes with uncontrolled diabetes causing complication manifested as retinopathy and peripheral neuropathy. And that's the cause of recurrent fall in this patient. So you will just explain that most likely the cause of your recurrent fall is uncontrolled blood sugar causing peripheral neuropathy and retinopathy. In this condition, the nerve that supply your lower leg get affected, causing the numbness and tingling. That's why sometimes you might not even feel where you have been stepping. Also, we have found some eye changes related to diabetes, which is affecting your vision, called diabetic retinopathy. Together, both of this is contributing to the recurrent fall that you have got. Other than that, you are also having some knee joint changes, which can lead to recurrent fall as well. And then give all the differential diagnoses one by one. Okay, so it's all about differential diagnosis in this kind of case. If management comes in this case, then the first thing is, if you have found this patient is diabetic, you need to check the patient's diabetic control and all. So you need to organize all the blood tests, so including full blood count. You'll check their liver kidney function. You will do blood sugar level, especially HbA1c. You'll check their lipid profile to check the cardiovascular status, right? What else we would like to do? You would like to do a ECG on this patient. Right? So full blood, liver kidney functions, or urea electrolyte creatinine, blood sugar, HbA1c, lipid profile, ECG. These are must to add. Also, because this is an uncontrolled diabetic, you can check for microalbumin urea. So you can do a urine albumin creatinine ratio to know whether the kidney is getting affected because of the diabetes. You will also send this patient to an optometrist to check the eye in detail because you have found features of diabetic retinopathy. So this is your initial management. And also, any recurrent fall patient, you need to organize a aged care team assessment. So you'll say that, first of all, I will do all this investigation. I will send you to an eye specialist to check the eye in detail. And also a aged care team will be involved for proper assessment of your home situation. So aged care team involves me as a GP, who will be the center of all these people. And then we will also include a occupational therapist who will come to your home, assess your home situation. They will check whether there is any loose carpets, whether there is poor lighting. They will check if you need any shower rail, whether you have a stairs at your home and it needs rail. So they will check all of them and make your home safe for living. A physiotherapist will come to your home and he will show you some exercise to increase the muscle strength of your leg, which is already you are doing anyway. We can also involve a social worker who can help you with your daily chores, like they can help you to take you to the shop. They can help you with your cooking and cleaning the house as well. So all of these people will help you to give you a proper quality of life, and our main goal will be to reduce the recurrent fall that you have got. Okay, so that's usually the treatment for recurrent fall. Find out the cause, treat it properly. And also this patient, because of uncontrolled diabetes, you need to send the patient to a diabetic educator, a dietitian, and also you need to send the patient to a diabetic endocrinologist to check up the patient in detail. Okay? So all of this will be included in the management. Make sense, everyone? You don't need to do it, Dr. Aryan. Monofilament test, we can, you will not have that much time in the exam. We don't need to do fundoscopy by ourselves, no. Not in here, but there are the physical examination cages are there where you need to do. Quickly, there was a case, as I was mentioning, that postural hypotension due to UTI. So that was the case we have seen. So if you got a patient with postural hypertension, you couldn't find anything, but you found that patient having this urinary urgency frequency, and then you did a urine dipstick, you found that patient has a leukocytes nitrite, then you know that it is UTI causing the postural hypotension. So first you explain that you have got postural hypotension, explain what it is, and then say that in your case, it's most likely due to an urinary tract infection, as you have fever, burning sensation during urination, and increased urination for the last few days. Because you are going to the toilet more than usual, this can reduce the amount of fluid in your body, making it harder for your heart to pump enough blood to your brain, especially when you suddenly stand up at night. In addition, during infection, your blood vessels gets wider, causing pooling of blood in your leg, and it can cause further reduction of blood flow to the brain. So that's what your explanation is, that why UTI causes postural drop. First, patient is going to the toilet a lot because of increased frequency of urination, causing the reduction of fluid volume, especially for elderly patient, that can be enough to have a postural drop. And also, because of infection, their blood vessels gets wider, causing the pooling of blood. Please do not stress, as we can treat the infection with an antibiotic such as trimethoprim or cefalexin. Now, based on the age of the patient, you can choose. I normally don't like to put patient who is elderly on trimethoprim, but again, trimethoprim still is the first line UTI medication. So the second line is cefalexin. I usually like cefalexin. So it doesn't matter. You can either use trimethoprim or Keflex, and you should start to feel better within a few days with the antibiotic. Okay, that will be the explanation for this patient. Any questions, guys? So that's all our cluster-wise approach. So you can understand that there is a lot to learn. And with the course, my idea is not just to pass the examination, it's also to be a good doctor. So that when you talk, people will know that you are knowledgeable and you know what you're doing. And that is important to be a good doctor. It's not about just passing an exam. It's also about how you are learning. The learning process should be smooth, should be nice and clear. You should not have any doubt in your mind that why I am doing this test for this patient, why I am doing this management for this patient. You should know why. If you don't know why, that is a problem. Okay? So, and when you know these kind of things, you will have the confidence. Because when you go and know everything in your back, that yes, I know how postural hypotension happens, I know how to diagnose this patient, your voice, your tone, everything changes with that confidence. Okay, so it's really important to know these things for you to become a good doctor, because you will be working in Australia, and I'm sure you will always remember what you are learning from here. Okay, so be a good doctor, be the best doctor, be the best version of yourself. That's how we usually would like you to prepare. Okay. So Dr. Mona, POTS is a very complicated thing, and it is not a topic that we should discuss just in 1 minute. But if you want to know the easiest way to differentiate between POTS and postural hypotension, so postural orthostatic tachycardia syndrome, both of these blood pressure will drop when they stand. Okay, but their tachycardia level or reflex tachycardia will be exaggerated in POTS. So POTS patient, most of them has very low strength or muscle or blood vessel strength in the leg. So lean and thin patient or very tall patient. So you will see that postural hypotension, when they stand up, their heart rate will be elevated, but it will be less than 30. But POTS patient, their heart rate will be elevated more than 30. That's how we can at least think that which one is POTS and which one is postural drop. But there is a lot of things in these patients which is out of scope for this class. All right, so that's it for tonight, guys. So I hope you enjoyed our session. I hope you learned things that's important for exam, and there will be another cardiology session. So the session that is written as cardiology role play, we'll be doing the cardiology session 3 there. Okay. Thanks, everyone. Have a good night. See you soon. Thanks. Bye.